Hello, everyone. My name is Ariel Avgar, and I'm a faculty member at Cornell University's ILR School and director of the Center for Applied Research on Work. And I'm thrilled to welcome you all to this session, Worker Militancy, Healthcare Conflicts and Possible Solutions, which is a third in a series focused on the rise of organizing and collective action in the United States. Together with my fellow panelists, we will spend the next hour talking about the state of the healthcare system in the US, with an eye towards the role that labor management relations can play in addressing the range of dramatic challenges and some opportunities. We will also ask the fundamental question about the extent to which labor relations has the potential to serve as a tool through which to fix an arguably broken healthcare system. Joining me today are Deanna Dudley, Chief Human Resources Officer at Camino Health, Rob Baril, President of SEIU Healthcare NE, a union of healthcare workers in Connecticut and Rhode Island, and John August, Director of Healthcare and Partner Programs at the Scheinman Institute here at the ILR School. I'd like to have each of our esteemed panelists do a quick introduction with a bit of background regarding their experience in healthcare. And I have to say that it's really exciting to be on a panel that brings together leaders from both the labor and the employer side of the bargaining table. So I'll turn it over to you, Deanna.
Thank you. Hi, everybody. Thanks for joining. I am Deanna Dudley. I am currently the Chief Human Resources Officer at Camino Health. We are located in Mountain View, California. Prior to joining Camino, I worked at Kaiser Permanente in a number of leadership roles, and that is where I met my fellow panelist, John August, when I was actually over the Office of Labor Management Partnership and dealing with national labor relations. Prior to Kaiser, I was with the University of California doing labor negotiations for their system because I was at the Office of the President. And I started my career dealing with these issues as a practicing attorney in employment and labor. So I've been dealing with these issues and seeing the progression throughout the years for quite some time. Thanks.
Great. Thanks so much, Deanna. Over to you, Rob.
Hi, everyone. I'm Rob Baril. I am president of SEIU 1199 New England, which is a local of about 30,000 members between Connecticut and Rhode Island. And we really represent the full range of healthcare professionals in long-term care, home care workers, nursing home workers, and group home workers. And we also in Connecticut represent about 6,000 state employees who are really safety net workers caring for folks with developmental disabilities and people with mental health and addictions issues. And I've been president of the local for 5 years now. So, have seen the organization together with other wonderful leaders through the COVID pandemic.
Thanks so much, Rob. And over to you, John.
Hi, everyone. John August, spent most of my life in the labor movement. Kind of divided between working in healthcare and 1199 SEIU and a long stint in the Teamsters Union as well. I had the opportunity kind of late in my years of work in the labor movement to have the frankly life-changing experience of leading the coalition of Kaiser Permanente unions and being co-chair of the National Labor Management Partnership. Did that for 8 years. And then for the past 10 years plus, I've been at Cornell. And at Cornell, I've had incredible opportunities to participate in labor management relations at many levels. And among the things that have been most influential is 5 years I spent on the oversight committee of the Delivery System Reform Incentive Program, which was the Medicaid reform program in New York State, where I really got to see system level change. And I've also spent a lot of time working with the New York City Health and Hospitals Corporation, the largest public health system in the country, and many other opportunities in labor management relations.
Great. Thanks so much, John. As a way to set up our panel discussion, I'm going to say a few words about the U.S. healthcare system overall and the patterns of collective action in this area. Now, there are a lot of ways to sort of think about our healthcare system and to try to understand some of the monumental challenges that we face. And I like to think about the contradictions that characterize our healthcare system. There are a number of inherent and ingrained contradictions, and I want to highlight three that I think are especially helpful for our discussion today. First, we, and by we I mean public and private actors, we make massive economic investments in our healthcare system in the US with mixed and uneven patient care outcomes at best. In fact, if you look at our standing in the US among other countries with similar levels of investment, our patient care quality is lagging behind, to put it mildly. So that's one core contradiction that I hope we talk about today. Second, and very much relevant to our discussion, as is the case in all healthcare systems, ours is one that relies heavily on workers to deliver high quality, safe, and effective care. And by workers, I don't just mean doctors and nurses. Our system is reliant on a large, low-wage workforce that is central to caring for patients. Nothing, of course, brought this centrality or essentiality to the fore like the COVID-19 pandemic. But at the same time, our system struggles to maintain good working conditions and adequate voice for all workers across different providers and healthcare organizations. There are, of course, bright spots and leading organizations that we'll hear about today in this space. But again, this is an uneven portrait. And finally, the healthcare industry in the US offers a tale of two labor relations models. On the one hand, the vast majority of labor management relations in this sector can be characterized as traditional or conflictual, with an indication of growing reliance on strikes and collective actions as a mean of reconciling competing interests. But on the other hand, the healthcare industry has seen some of the most longstanding, creative, and powerful examples of labor management partnership and collaboration. And given the background of our panelists, I'm sure we'll be talking about both of these models today. These are by no means an exhaustive list of the contradictions that our healthcare system faces, but I hope that they help to clarify some of the tremendous difficulties we face in improving healthcare delivery and outcomes. Last comment before turning it over to my colleagues. This session is taking place, as I noted, in the context of a clear uptick in labor relations activity in healthcare. We are seeing increases in organizing efforts, and has been widely covered in the news, strikes and collective action, even in what has been referred to as collaborative labor management settings. According to the ILR Labor Action Tracker, developed by my colleagues Johnny Callis, now at the University of Illinois, and Eli Friedman here at Cornell, between January 1st of 2021 and January 1st of this year, 2024, there have been 122 strikes across 238 locations in the healthcare setting. And if you include labor protests, that total rises to 478 labor actions in over 600 locations. As I turn it over to my fellow panelists now, our task is to try to unpack what does this rise mean, what explains it, and what are the consequences for patients, workers, and employers. So with that, I'm going to turn it over to Deanna, Rob, and John to help us make sense of these trends. And I want to start, Rob, if I can, with a question that I'll ask all of the panelists, but start with you. What are some of the factors that help to explain this increased collective action, conflict, new organizing in the healthcare setting over the last few years?
Ariel, I thank you. That I believe is a wonderful setup and a great question. I would start with a few factors. One you alluded to, which is that while most of the healthcare system in this country is privately operated, many of the dollars are public dollars. So primarily from Medicaid, secondarily from Medicare. You've got tremendous amounts of public investment in the healthcare system, but once it is turned over to private corporations, there's often very little in terms of regulations that takes place about how that money is dispersed to workers in the form of wages, benefits, staffing, and other priorities. So I would say that that's one piece. Secondarily, I would say that we with respect to government funding, but also worker conditions, really since 2008, the Great Recession. We've been in now a decade and a half of austerity. So there's been downward pressures on payments to workers, in the form of Medicaid and Medicare rates. And employers have oftentimes, sort of squeezed what funding comes from the government in a way that has not wound up in workers' pockets. And then the last thing I would say that you mentioned is again, the pandemic created just unbelievable stresses on workers. And then when that was followed up, obviously, with inflation, it's meant that workers are in a mood that is quite restive. Folks are absolutely feeling the pressures of declining purchasing power, greater stresses, as I talked about, in terms of what is taking place in the workplace. And I think a general sense that in healthcare, as in the broader society, we're seeing a divergence between compensation at the executive level and wages and benefits for the frontline workforce. So in places where people have organization, where people are part of a union, workers are absolutely asking us as leadership in the labor movement to address those concerns in bargaining by putting ourselves in the position where we can wage fights. That's how we view it. It is in the traditional sort of antagonistic labor management relationship. Workers are demanding that we push harder to get what has been a declining share of income that workers receive within the healthcare workforce and the broader healthcare economy.
Thanks so much, Rob. I have so many follow-up questions I'll try to squeeze in, but I'll turn to Deanna again to get your sense of what factors help explain this shifting labor relations landscape in the U.S. healthcare system.
Thanks. At the end of last year, 2023, I was fortunate to have an op-ed piece published in the Perspectives on Work magazine. And in that op-ed, I actually listed a couple of factors that go straight to this point, right? So during the pandemic, we identified this group of workers as essential workers, right? They became our everyday heroes, from truck drivers, school teachers, grocery store employees. They really kept us going, and hospital staff, number one, top of that list, right? And as we came out of the pandemic, what I would say, all of these workers emerged with a voice, a newfound voice that our society had not heard before, and they recognized the contributions, significant contributions that they were making. And so I would say that this voice that we had not as a society heard before was not going to be quieted. And to what Rob said, the pressures that are going into healthcare with regard to inflation, we look at burnout, we look at a number of stressors that healthcare workers especially had to endure during the pandemic. We basically asked them to put themselves at risk, right, before we had vaccinations to save others. That is really what they did by showing up, and they did so. And so now they would like and should have input into what is going on with their organizations. And that's what I believe we're definitely seeing in the healthcare space, right? Healthcare workers have supported us as a society, and they're demanding, as Rob said, that organizations take care of them, help them provide for their families, and provide them with some input as to how things are being run in organizations.
Great.
So I would say that's a large part. Sorry, Ariel.
No. That's great. Thank you so much, Deanna. John, over to you with this intro question, and then I have a follow-up for both Deanna and Rob.
Thanks, Ariel. My view is that, as you pointed out in your opening remarks, to put it mildly, we have a broken healthcare system. I like thinking about former Surgeon General Jocelyn Elder's view of healthcare, which is we do not have a healthcare system in the United States. What we actually have is a sick care system in the United States, meaning We do not live in a world of prevention. We do not live in a world of advanced investment in population health. And so I think that the pandemic ripped off the bandage that has been leaking for 30 or 35 years, in that we have a sick care system which intervenes very expensively, usually for care which could have been for prevention instead of acute care. So the pressure of that system has created the kinds of conditions that Rob and Deanna just spoke about, which were exposed during the pandemic. But my theme for today, Ariel, is going to be that I think it's long overdue that we together think of innovation together so that we can begin to solve these problems, as opposed to keep coming back to the same kinds of conflict and inability to solve problems, which are very much a part of a broken healthcare system. We're not going to change very much in labor relations unless we do it ourselves from the bottom up and together.
Thank you so much, John. Before moving on, I want to kind of build on the comments, Rob, that you made and Deanna that you made. You both talked about shifting expectations on the part of your members, Rob, and the part of your employees, Deanna, in terms of voice and working conditions. And I wonder, maybe we'll start with Deanna, what are some ways in which your organization is adapting strategically to meet this shifting expectation of, as you said, that they discovered voice and they want more of it now? How are you responding? And then I'd love, Rob, to hear about how it's impacting your kind of strategic efforts at SEIU.
So in my organization, what we're doing is, and Rob, you brought up a very good point when you said, kind of the demands and more of the fight as it relates to labor and management. We're actually trying to move in a different direction. We're trying to be more collaborative. We're trying to work together to find solutions that work for both of us. Last year, for example, we had our nurse negotiations. And during those negotiations, we talked a lot about development and opportunities and what that means for nurses as they progress. As it relates to SEIU, we are a contributor to the SEIU Education Fund, and we work with the fund. And Kaiser is also a part of the SEIU Education Fund. And I remember when I was with Kaiser, literally partnering with the fund to identify programs to help educate our current employees to move into different roles that the organization needed filled, right? So we're trying to come at the situation because staffing is an issue. We all know that the generations are set, right? So our generations are not going to get bigger. So it's what are we doing with the people that we have in the workforce now? Because we have so many leaving. So I am on the side of collaboration, building together, creativity and problem solving and solutioning. And I've been fortunate to be with organizations who have taken that approach.
Thank you so much. In a moment or in a few moments, I'd like us to talk a bit about the relationship between labor relations and patient care. And then maybe we'll come back to that notion of a collaborative partnership approach when we have that discussion. Rob, how have these demands or the kind of expectation that you fight more, as you put it, playing out in terms of your strategic orientation?
Yeah, I would say that we have a few ways that we try and address that. The first thing is that in many cases, our negotiations are in some ways, the negotiations with an employer over a contract is secondary in so many cases to the political lobbying that we do at the State House to make sure that, in particular, Medicaid rates are increased such that there's actual funding available to pay for worker wages, benefits, and staffing conditions. That has, some pluses and some minuses, right? It shifts the focus away from the day-to-day decision makers. Again, public money is often handed over to employers in the private sector without a whole lot of strings attached, but at least if the pot is bigger because the Medicaid funding is increased, there's something to go into for workers to attempt to gain in negotiations. So a much greater focus on political action for one thing. Secondarily, we are absolutely attempting to, I would say, to go big to meet the challenges of the moment. What does that mean? In 2021, we negotiated contracts in long-term care nursing home facilities that took workers from $15 an hour to $20 an hour. We were all really busy patting ourselves on the back. Well, despite a 33% wage increase, inflation has now meant that those $20 an hour wages are far insufficient. So we're having to sort of up the scale of what we're projecting out as needs in terms of wages and benefits, significantly larger than we had to in the past to deal with contingencies and to deal with makeup. I would also say we're looking at as much as we can at internal opportunities to sort of grow our own, to upskill workers in terms of technical and professional skill, so that the staffing crisis is met from within. So that means more money for things like education to become nurses, to become surgical techs, to become therapists. The full range of healthcare opportunities are things that we fight for in our contracts. And lastly, where we have the ability, we do want to have partnerships with employers. We've been able to achieve that in a limited sense in Connecticut with nursing homes and group homes. We meet with the associations who are partners in some senses in attempting to achieve funding solutions. We do the same work at places like Women and Infants Hospital in Providence, Rhode Island. But of course, all of those efforts at partnership are challenged, I think, in many ways by the fact that the day-to-day issues in terms of the stresses and pressures that we've talked about have meant that conditions between labor and management are often quite polarized and quite tense, right? Management is asking workers to do things that workers don't feel like they are compensated enough or supplied and staffed well enough to be able to achieve. So within the context of, I think, some very big picture and oftentimes not easily solved challenges and crises, I would say we often find ourselves in the position of attempting to manage crisis as opposed to being in a position to come up with real solutions. That's a reality.
Great. Thank you so much, Rob. So we've already started to sort of link broader trends in healthcare to the labor relations relationship or the labor relations landscape. I want to maybe give some time to do that a little more explicitly. And Deanna, if it's okay, I'll start with you with a question about kind of what are some of the factors such as technological innovation. Rob talked about financing models to some extent, kind of public financing models, but what are some aspects of new models for financing healthcare that end up affecting the relationship between labor and management? Again, both technological financing, but other big factors that those pressures end up infiltrating your relationship with labor and labor's relationship with management.
Well, I would say I do agree with Rob. There are pressures on both labor and management. So speaking strictly for management in healthcare, right? We're dealing with increasing costs as well across the board. We're dealing with reduced reimbursements. We're dealing with supply chain issues. We're dealing with, dwindling margins for our organizations. And sort of spotlight is the uptick in mergers and acquisitions. So the competition in the field of healthcare is really becoming quite fierce. And a lot of healthcare organizations are struggling financially. And at the same time, to Rob's point, unions are putting demands on healthcare organizations for higher across the board salary increases. We're actually seeing, at least from my perspective, higher across the board salary increases percentage-wise than we've seen in a long time. And I've actually been doing negotiations for quite a while. So this pressure that is on employers in healthcare is quite significant. And then you overlay that with innovation and technology, right? How work is getting done. It is, and the fear that employees have about replacement, right? I've been fortunate to be part of organizations that actually try and use technology to supplement the workforce, to help the workforce, not as a strategy to replace the workforce. But that fear and those factors do cause polarization in some cases, and it makes it hard for labor and management to actually work together during certain issues that they're addressing. So I would say that employees are faced with the inflation and, like I said, the concern of new technology coming in. And what does that mean? Right now in 2024, and we saw in 2023, now we're looking at advanced analytics and AI. And how is that going to really impact the work and how it's done for healthcare organizations and their workforces?
Thank you so much, Deanna. Rob, can I turn it over to you with the same question, but maybe adding this notion that Deanna talked about, or this trend, which I think is a kind of fourth contradiction in healthcare, that at once we see increased consolidation that influences competition, and yet a fragmented system. Even with this consolidation, our 6,000 or so hospitals and 28,000 or so nursing homes are fragmented into regional or local systems or individual providers in the public and private sector, with nonprofit and for-profit entities. This is a mishmash that makes it difficult, of course, for employers, but must make it difficult for you in the labor movement.
Look, I think that if any of us were, king or queen of the world, and we were to, design a healthcare system from scratch, this would not be it. Yeah. And to Deanna's point about the levels of consolidation that are taking place in healthcare, that has all types of impacts. I mean, one of the states in which our local is centered, you essentially have two healthcare systems that are in competition with each other and driving rates for services, through the roof. So that if you compare, for instance, a cost for a hip replacement, between the most affordable hospital in the state and the two leading competitors, there's about a 250% difference for the exact same procedure, with a negligible difference in terms of outcomes. And of course, that has all kinds of knockoff impacts. So I think that from the standpoint of a worker organization attempting to impact healthcare policy at a in many cases statewide level, it just creates some real challenges, because the corporations that we are I was going to say partnering with, in the best cases partnering with, but in most cases that we are dealing with in an adversarial fashion, there's not an even power relationship. Okay, the corporations are much more powerful than I would say organizations of workers are, and it makes it very difficult for workers to get heard on the places in which the healthcare system just is not meeting needs of workers and patients. I'll use one example. Nursing homes, as I think many people know, were sort of the epicenter of the pandemic. Our membership is reporting in nursing homes in Connecticut that staffing is worse than they have ever seen it. I'm talking about 35, 40-year employees who are saying, I came into nursing homes because I wanted to care for people in their end stages of life. And I'm now I would never put a relative of mine in a nursing home. We're hearing our members saying things like that. So the system is in many cases, I think, in real breakdown, and we're not seeing the type of leadership from federal and state regulators and decision makers that would be necessary to revamp a system that is frankly, desperately in need of reform.
Thanks so much, Rob. John, I'll turn it over to you for the kind of thinking about broader factors as Deanna and Rob did. I want to embed a question that we received from the audience. Touches a little bit on things that we've already talked about, but if any of you want to address it after John remarks, you've both talked about the desire to collaborate in one way or another, Deanna and Rob. Are there opportunities? Steve asks us for some quick wins on both sides, pay raises for nurses, hiring more staff, and so forth. So, John, I'll let you respond to the first question, and then maybe as we move forward, we can address Steve's question, and I'll integrate some of the other audience questions as we move along.
Sure. Well, I tend to look at labor relations, I think, the way we all do and we all should. And that is that labor relations ultimately is an exercise in the use of power. I happen to think that if you look at the data about where most of the organizing activity is and most of the collective bargaining conflict is, it tends to center in areas where there's a lot of power actually on both sides. California, New York, and other places. We should remind ourselves that 80% of the healthcare workforce remains unorganized. So while the parties are, if you will, duking it out where they have power, 80% of the industry is kind of laissez-faire and doing whatever they can, which is living with conflict, but conflict that is more buried. And so I think that we got to keep in mind that this use of power, I happen to think, is really something that is undervalued. I do think that one of the most important things that comes out of the Kaiser Permanente labor management experience is the notion of using truly innovative, in-depth, interest-based bargaining. And I want to be really clear about what that means. It's not just a different way of doing bargaining. It's where parties, both of whom have tremendous power, you're talking about 130,000 unionized workers who are in coalition and a company that is close to $100 billion corporation. They have tremendous power. But what they do most of the time is before they start bargaining, they make a list of the most existential problems that they have to face. Workforce planning and development, health of the health plan, preserving the best wages, pensions, and benefits in the industry, workforce planning and development, and maybe most importantly, how do we engage the workforce in continuous improvement of our services and our quality? And I think that the big lesson from that is that I think that where parties have power, I think Rob is right. Sometimes the power is out of balance, but in many places there is a lot of power. And I think that it's overdue for the parties to begin to look at some of these problems that create the conflict and begin to solve them together. And frankly, come up with solutions that go to their state government and to some degree using the federal government to invite them to be partners in the solutions as well. This can be very much a part of how you do workforce planning and development, how you build infrastructures for prevention and electronic medical record systems, how you can actually leverage federal and state dollars to support efforts. But that's not going to happen unless there is some use of that joint power to be able to solve problems for others to help participate in. Finally, I want to say this, that there is some new organizing going on in the United States that we should not ignore. In fact, we won't be able to. The Committee of Interns and Residents has more than doubled their membership in the last couple of years, and attending physicians, for the first time in history, are organizing unions more than ever before. And I think that the challenge for labor there is to seize this opportunity, to respond to this opportunity with a lot of innovation in how you start bringing physicians into this mix, because they have an awful lot to contribute. And I think that it could be the next big effort in how the labor movement begins to think about its role by this new and incredible outpouring of doctor sentiment to belong to unions.
Thanks so much, John. Before moving on, I want to kind of make my own comment on something that Deanna, John, I think Rob, you as well talked about in terms of the kind of adoption of technology, new innovative technologies. either clinical technologies or technologies designed to collect and analyze lots of big data. And just say that often in organizations in general, but we do this in healthcare in particular, is we view technology as if it has a predetermined outcome on workers and on patients. But really, it's the adoption of the technology, the implementation by workers themselves, by unions, and by employers that determine what role will workers play in that adoption process. My colleague here at Cornell, Adam Seth Litwin, talks about a worker-centered approach to technology adoption. And I think it's important to note that organizations vary quite a bit in terms of the extent to which they do what Deanna talked about, either using technology to complement worker centrality, worker essentiality, and sort of assist them in upskilling and advancing the roles they play within their organization, to organizations that use it or attempt to use it as substitutes for workers in the roles that they play. And so we see variation in how this plays out. I want to, in a moment, move on to a discussion on unions, labor relations, and patient outcomes. We've touched on it, but I want to get a little more specific about it. But I do want to address a couple or maybe one question from the audience at this stage. We had a question from Samantha. I'm going to turn it over to you, Rob, on this, because Samantha asks which unions, and I'm sure 1199 is going to be one of them, but which unions across different states are leading the way as far as rallying support for these important issues that we've been talking about. Maybe Rob, and then John, if you want to weigh in, and of course, Deanna as well.
Look, I mean, across the labor movement, I think that we're seeing that multiple unions are stepping forward. But in healthcare in particular, SEIU in many states across the country is doing some quite fine work. I mean, Washington State in home care and in hospitals, 1199 Northwest and Local 775. In California, United Healthcare Workers West. In Pennsylvania, SEIU Healthcare Pennsylvania. Those are a number of organizations amongst several others that are doing very, very innovative things across different parts of the healthcare workforce to meet the needs as we are dealing with so many different and in many ways competing trends in terms of resources. So we're trying to have a voice in terms of how home care becomes a place where people can receive elder care. We are participating within the acute care setting in terms of making sure that in places where maybe technology is not implemented in the way that Deanna described, where it supplements worker activity and worker role, where in other cases it may be seen as more of a threat. The union is attempting to bring worker voice to those concerns. So there are some wonderful things taking place, and I think that what we oftentimes lack is some clarity at the state and at the federal level, as John was alluding to, about the people who really have the opportunity to redesign the healthcare system, stepping forward and playing that role at the government level.
Thanks, Rob. John, anything on that front? Things that you're seeing, innovative responses by unions across the different states?
Well, I see some of it, and I want to see more of it. And what is the it? I think that there's three areas where unions, I think, would find it in their immediate interest, along with management, to begin to work on together. And that's in the area of social determinants of health, the reality of more and more risk-based payments called value-based payments, and disparities in the way healthcare is experienced and delivered based on race and ethnicity. Those are areas where both parties I would think, would be shoulder to shoulder on making happen to avoid some of the pitfalls and to establish real goals that they could work on together. Some of that could be enhanced by use of technology, indeed. A lot of it would have to do with a kind of reconfiguration of the communication at the unit and department level to establish goals together and actually achieve them. I think that one of the things that I think that labor and management need to come together on, and that is to deal with consolidation in this sense. I think both parties can agree that they want to keep healthcare local. And more, what consolidation means is that people from other parts of the world, including private equity and so on, are going to start determining local healthcare. And it seems to me that while consolidation is a huge threat, certainly to unions being able to maintain their standards, I think there's an opportunity again where union and management can identify a joint use of power to make sure that they are making their health systems the best possible quality and efficient systems that they can be, so that they can avoid takeovers by people from outside. I think those are all issues that the parties ought to look at carefully, and I think can find a lot of common ground on.
Thanks so much, John. Deanna, any comment on your end? Are you, in terms of what you see from your vantage point of kind of labor and places where things are going better?
Well, what I would say as it relates to technology, especially, prior to leaving Kaiser Permanente, I was involved with negotiations with the Alliance of Healthcare Unions. And as part of that agreement, actually, there is a labor management committee focused on technology and innovation, right, at that organization, so that as new technology is coming into the workplace, how are we working with our employees in the rollout, like you said, the execution of that technology, to help them in their roles, to help there be greater adoption. And I think that those conversations are actually really important because, as I mentioned before, bringing in technology, there's more technology and innovation happening nowadays, more so than ever, but making sure employees understand how to use it, benefits of it, how to make things better, because at the end of the day, the focus for each healthcare organization is to try and improve outcomes for all of our patients. Patient care, the results of improved healthcare, is really our core business, if you will.
Thanks so much for that, Deanna. It's a perfect segue to the kind of maybe one of the last pieces that I want us to talk about this hour. And that's the role that labor management relations can and should play in delivering, as you say, high quality, safe, effective patient care in the face of challenges, aging population, and a myriad of other quality of care challenges. So, John, maybe I'll start with you on this question. What role can and should unions play in addressing patient care quality?
I think they should take the lead on it. And I think they can take the lead on it because the healthcare worker comes to work for that purpose. There's almost no healthcare worker that signs on for this work to become wealthy. They sign on because they want to contribute. And I think that we know that where people are given the opportunity to participate in the use of data to learn the science of improvement, to be active participants, where, as we like to say, everybody takes their name tag off before they come into the room, where everyone is equal in terms of being able to identify problems to solve in improving care. I think that that ought to be core to the future of healthcare labor relations, to establish that kind of opportunity for people to work together at the unit level to improve quality, the patient experience, to make things as efficient as possible, while at the same time paying close attention to people having the best possible place to work. To see, if you will, that there's not a trade-off, but there's really a kind of similarity in achieving improvement for patients and improvement for workers by being able to make that improvement on a continuous basis.
Thanks so much, John. Rob, can I turn it to you on this question? How do you and the union and your members view the link between what you do at the bargaining table, as you said, what you do on the political front, and what you do in terms of organizing new members and delivery of patient care?
Again, a great question. Certainly we understand that the political work is critical, right? We really cannot come up with solutions that approach any level of scale on the facility by facility or employer by employer basis. So that means that where possible, that we do develop partnerships with employers that deal with questions around funding, and in certain circumstances with an alternate approach, an interest-based approach, as John has talked about, in terms of day-to-day problems that the workforce is encountering. I would say that in addition to having a broken healthcare system, we also frankly have a terribly fractured and broken labor relations regime in this country in terms of labor law that has not worked for working class people for decades, probably since the 50s. What that means is that for workers to even have a voice means that they have to overcome tremendous resistance to get union organization. John talked about 80% of the workforce in healthcare not being in the union. So in places where we don't have enough power based on representing workers within a particular sector, that's actually where there tends to be more and more conflict. We are attempting to organize in those parts of the healthcare economy and meeting with a whole lot of resistance. And until we can force employers to sort of accept that workers need to have a voice, that there tends to be quite intense conflict. Once we reach a certain plateau, that relationship can change. I mean, the Kaiser Permanente partnership is one that emerged out of conflict to try and look at doing things differently. So we're hopeful that we can make those strides, but there are some limitations, I would say, until we gain enough power that employers understand that they have a vested interest in working with us as opposed to against us.
Rob, can I push just a bit more on that? And so once you go through that process that you just described, where's the link to patient care, right? I mean, so often we received one question. I don't know that I'll have enough time to ask it in full. We received a question that in some ways says, well, aren't unions just trying to advance pay and benefits for their members and not thinking about the broader system? That's not exactly how the question was phrased, but I'm paraphrasing. And I think it's important to sort of think about the role that unions and labor relations more broadly, the labor management relation, play in not just advancing sort of better working conditions for employees, which is essential, but also delivering patient care. How does your union think about that link?
Look, I mean, to be clear, no healthcare worker, and I'm not just talking about professionals like nurses and doctors, no healthcare worker goes into working in the healthcare workforce just based on motivations around money. They come with an orientation towards their vocation as being caregivers. So, from staffing to training to, frankly, even program and policy design, our members are clear that they have ideas that they want to be able to be listened to and to be heard on. And again, in places where we have a more receptive management, we can go much further in terms of creating healthcare outcomes that actually, are patient focused. It is more challenging where the relationship is more adversarial. But as often as possible, we want to be speaking with a voice that is direct about wanting to see patient care outcomes improve.
Thank you so much, Rob. Deanna, can I turn it to you? How do you view your labor relations role and labor relations in general, and the link to the delivery of good, high quality patient care?
So thank you for letting me answer this question, because I sat and I listened to John, who talked about the healthcare worker. And I'm going to say that I really believe that it is the responsibility of both healthcare worker, right, the workforce employees, as well as management, right, to ensure that quality is at the center of the care that is provided. With regard to the healthcare workers, of course, the employees come to work. They are delivering, right, the service and the care. We need to find ways to support our employees and our workforce so that they are able to do it. So an example of that is staffing, We know that there have been notable staffing shortages in healthcare because people are retiring in greater numbers, and it has just been a struggle since the pandemic, and it is projected to get worse. So we know as employers and management that we have to find ways to support our workforce because they're still suffering from burnout. So we have to be able, as employers, to look for creative solutions that we may not have used in the past to try and address that. An example, I was talking to Eric Alvarez, who's the founder of Grapefruit Health. And Grapefruit Health is looking at creating a clinical student workforce that can come in and supplement, right, healthcare organizations so that we can free up some of our current employees so that they can, work at different levels of their scope of practice, whatever that may be. That's an innovative, different type of solution that a lot of organizations aren't using right now, right? Because we're just looking at them as clinical students, as opposed to how can they actually help our workforce. So management has to look at ways to help support the workforce through these challenging times, but also unions have to be willing to be open and flexible with some of these creative models that we can put in place to help their members get the work done, right? So it's a two-way street for us. We sit down, we negotiate once every 3 years, once every 4 years. Okay, that's not the new way we need to do work. Yes, we'll have the contract will have its provisions, but I'm talking about an ongoing dialogue because these issues that we are experiencing in the healthcare industry, they don't just come around once every 3 years. They're dynamic. We haven't dealt with them as a society before, and they will take continued creativity in order for us to really continue to focus on quality of care. And I am fortunate to be at El Camino Health, which actually prides itself on care, right? We're Leapfrog A, we are Magnet, we're 5-star. I mean, but it takes both. It takes the work employees as well as management to be focused on creative solutions.
Thanks, Deanna. Before I kind of bring us to maybe a little bit of a wrap-up discussion, I want to say 2 things on this front about the link between labor relations, unions, and patient care. The first is to build on something that Rob said and Deanna talked about often, and again, one of the questions we received from the audience kind of gets at this. Often there's a notion or a sense that collective bargaining or strikes are solely for the purpose of economic or employment benefits for workers, better pay, shifts, et cetera. But we know, and I'm going to talk just a bit about some of the research, I'm going to say this very briefly, we know that many of the issues that drive workers to organize and to bargain and to take collective action are inextricably linked, as was said by the panelists, to patient care, right? Staffing ratios, Deanna just talked about staffing, and staffing ratios are not just about work-life balance for workers, they go to the heart of patient care. Addressing burnout, a theme that's come up in our session today, it's not just about workers, but it's about care. Advancing worker safety and adherence to OSHA regulations. Here too, it's not just about workers, but it's about advancing patient safety. There is now a relatively long and established stream of research in my domain and in labor and employment relations that makes a really strong link between unionized providers, unionized healthcare organizations, and patient care. Articles going back to the early 2000s that document a relationship between unionized facilities in California and better outcomes after heart surgery. We know that hospitals that unionize often see a bump, an increase, an uptick in patient care after unionization. And in a recent study by Dean and colleagues focused on COVID, which we touched on during this session as well, unionized nursing homes saw about 10% lower mortality rates during COVID than their non-union counterparts. So I think it's important in the context of the reason this discussion is so essential is because what happens at the bargaining table, and to Rob's point on the political front, matters to patients. Okay, we have about 4 minutes to wrap up, so I want to turn to each of our panelists to sort of maybe say one or two. Rob said to us at the beginning of this session, if we were to build this healthcare system today, it wouldn't look like it does now. What are one or two wish list features of a healthcare system and the role that labor relations plays within it that you would see if we were building our healthcare system today? And Deanna, is it okay? If it's okay, I'll start with you.
Well, if we were building it today, I think that it would be good if we could actually start the conversation with both worker voices represented as well as management, right? Because then we're solutioning from the start together. There is no way, and I feel this at my core, there is no way for us to continue to provide high quality care, which each member of our society should have. That to me is a basic right. And I believe we are falling short as a society on addressing that because we don't have enough coming together. The fight should not be with each other. The fight is because we all have the same interest, and that interest is providing care to our patients. So let's get to talking, let's get to solutioning, problem solving, being creative so that we can do that for years to come.
Thanks so much for that vision, Deanna. I'll turn it over to Rob. Your one or two features of a better healthcare system.
Well, look, I think the single thing that potentially would make the most impact is if the federal government, as ultimately the primary funder, or at least the largest single source of funding within the healthcare economy, used its power to create certain standards that would deal with everything from staffing levels to compensation in terms of pay and benefits to workers, to the question of increasing monopolization of healthcare, particularly at the acute care level. The government, unfortunately, has sort of taken the perspective that public assets in terms of tax dollars are going to be handed over to private corporations with very, very little regulation. In a different world, we could see the regulators at the federal level using that power and that authority to make sure that worker and patient voice was as important as frankly the profit motive, which oftentimes is guiding the decision making within healthcare. So that would be my at the very top of my wish list.
Thanks so much, Rob. It's a great place to start. And John, I'll give you the last word here. We're almost at time.
Well, I think that in a society that spends $4+ trillion a year on healthcare, what's missing is the word purpose. And I think what we've talked about today are issues related to staffing, improved wages and working conditions, all related to what? All related to having, as Deanna said, every person in this country having the right to high quality care. But purpose ought to be defined very specifically. And for me, purpose should be prevention. And we need to use all of our creativity and all of our power to reorient the entire system around prevention of illness and injury, which would make for a healthier population and free up trillions of dollars that are now wasted on things that do not come close to preventing illness and injury in this country.
Thank you so much, John. I want to extend a huge thanks to Deanna Dudley, Rob Baril, and John August for your insights today. And a big thanks to our audience for joining us. Thank you all.